it's time to start this session. This is the live cases for the complex TVR. This session is the live demonstration from the China, from the Dr. Second Philippe, the hospital, Zhejiang University, and one lecture. I'm Hong from Korea. My co-moderator is the Philippe Genereux. And there is several panelists, Woo-Baek, Chung, and Dr. Garot, and Dr. Hayashida, and Kim, Kim, and Dr. Ko, and Dr. Ying from Taiwan, and Dr. Yu. Okay, I would like to start the live demonstration. Dr. Wang, can you hear us?
Leo, nice to meet you. Can you hear me?
Yes, clearly. Please start your cases.
Okay. So at first, I'm so sorry to tell you that Professor Wang has another commitment from the Zhejiang University, so he is unable to come here for the live demo. So I'm Dr. Xianbao Liu and Dr. Wang Wei-Hsian and our team together to do the live demo today. First, I'd like to introduce the case. Slides, please. And the patient is a 66 years old gentleman and a chain tightness for over 1 year. And the patient has the history of diabetes and the previous pacemaker implantation. Next one, please. And the patient is a low-risk patient. Next one. And from the echo, we can see right here, the patient is a severe aortic stenosis. And I think of valvular area is about 0.6 centimeter square, and the maximum velocity is over 4 meter per second, and the mean gradient is 43 millimercury, and the LVF is about 68%, and the left ventricle is not so large. Next one, please. So this is the EKG. Yeah, the pacemaker implantation, and we can see the pacemaker signal right here. Next one. And from the anatomy, we can see the annulus is about 24 millimeter diameter from the perimeter derived diameter. And the ascending aorta is not so large. Next one. And you can see the patient is a typical type 0 bicuspid the AIS, and the symmetrical calcification, and the leaflet a little bit thickening. Next one. The coronary height is good. Next one. This is a typical type 0 bicuspid aortic stenosis. Yeah, the angulation is also large, about 50 degrees, and the maximal ascending aorta about 42 millimeter. Next one. And the aortic arch, the angulation there is okay, so it's no problem for the valve. Yeah, we can pass it smoothly, I think so. Next one. This is a projection. And for the bicuspid, we usually just like the tricuspid, we will use the cusp overlap implantation technique. Next one. The femoral artery is good, so access is no problem. We will select the right femoral artery access today. Next one. So for the strategy of this patient, for the type 0 bicuspid AS, in our center, Professor Wang developed console solution. We named it a Taylor sizing strategy. Yeah, based on the CT scan, we select a proper balloons, the size of balloon, and then do the BAV and see what will happen. And we will see the waist and also the regurgitation, and then decide the downsize or not. Yeah, this is based on the supra-annular sizing strategy based on the BAV and the CT scan. Next one. Yeah, we classified it into 4 groups. Yeah, group A, they are severe, the waist and no regurgitation. Then we will downsize choice of the device. Next one, please. Yeah, so for this patient is a very typical type 0 AS low risk patient and 66 years old gentleman. So we would like to use the TAVR procedure for, and we will use 23 DMAD redilatation, and we'd like to choose to see the results. If there's waist and regurgitation, then we will choose 23. Oh, 是那个吧，是24对吧？24。Yeah, if there's waist and no regurgitation, then we will select 26.
Okay.
If there's no waist or
Okay.
regurgitation, we will select 29.
We have the discussion about your treatment strategy.
等一下。
Okay.
Okay, please.
Okay. Any opinion and comment about these cases?
Well, I'm Dr. Yin from Taipei. This patient is a type 0 bicuspid, but have not much calcium. So I think we can go direct to the TAVR without redilatation if the sizing is okay.
Any other comment?
I would say that in U.S., so Philippe Genereux here from United States, in U.S. and probably in Canada, the first thing we'll have surgery. Bicuspid, not very friendly for TAVR. Aorta, if the patient is small, might be changed as well. That said, I would say if this bicuspid, like was mentioned, the raphe is not too calcified as far as we can see on the CT scan, and then the coronary are very high. So I think that's all good sign for the patient. We could go S323, which is be a little undersized, but I think I like the strategy of balloon and also self-expendable. Pro 26 most likely versus 29. We'll see. Yeah.
Okay.
So I really like the strategy of the sizing of the Hangzhou team because it's quite important to identify which part is the smallest in the aortic valve complex. And the balloon sizing is quite old school, but it still works. I like this method. I'm using that too.
Other opinion? Actually, the patient age is 66, and the bicuspid valve is a little bit the younger for take the TAVR. And the concern is that the aortic size is so dilated. There is some chance of the annular replacement was required during after the procedure. So the first options I think is the surgery suggestion is the first option. Any comment about the panelist comment?
I have one question about supraannular sizing.
Dr. Liu, any comment? Why this patient was selected TAVR rather than the surgery?
Okay, thank you for your comment. So, the patient is over 65 years old. Yeah, and the anatomy is okay. So I think the patient is suitable both for TAVR and the SAVR. Yeah, so we communicate with the patient and the family. Yeah, they prefer to do the TAVR procedure. So I think it's okay to select the TAVR procedure.
Okay. Any other comment?
I have a question is the supraannular sizing by balloon. Is there any the data about the CT sizing is a taper type or conical shape of the bicuspid valve? I think it is important for the which valve size or the which valve type was implanted for these patients.
Yeah, for the valve type, so the self-expanding and the balloon expandable, I think both of them are suitable for this kind of patient. Yeah, so because we have, for this patient, we did develop the Hangzhou solution. We usually majority of the patient with the self-expanding, and we designed an RCT study for the self-expanding valve using the Absolute Pro. So for type 0, majority of the cases in our center, right now we use the self-expanding. So why we select the supraannular size strategy? Yeah, we combine the CT and the balloon valvuloplasty. So, because only the CT, so maybe it's not so accurate. So the anatomy, the annulus, the calcification, so we don't know accurately of the supraannular structure. So I think the BAV can provide more information about the structure of the annulus, right? The aortic root. Yeah, it will help us to select a right size of the valve.
May I ask what is the reason why this patient took the permanent pacemaker, and do you do the cerebral protection device in this patient?
Yeah, we will not use this. So because in our previous over 1,000 cases, just like the BAV, the symptomatic stroke is similar, is quite low. Just only the silent stroke, a little bit more than the tricuspid. Yeah, and also, so the Sentinel device is commercial use in China. So, however, it's quite expensive. So we should think more issues about the patient.
What is the reason why this patient received the permanent pacemaker?
Okay, just a 3-degree block, AV block, several years ago.
Yes. The reason why I ask about the very rarely the occurrence of some stroke in this patient. This patient, especially younger, is the maybe occurrence of the stroke is very fatal for the younger patient. That is the reason why this patient received the permanent pacemaker.
Okay, so I'd like to have a question for you. So in your daily practice, you usually use the protective device in your center?
So I would say that if there's one group that I would be more comfortable using Sentinel will be in a young patient, bicuspid with heavily calcified valve, which this patient has, or a valve-in-valve with leaflet modification or prior stroke. So I think this patient will receive, if we move forward with TAVR, he will receive a neuroembolic protection device.
Wei-Hsian, you have a lot of experience of it.
Yeah.
Please.
Actually, if you see the paper, bicuspid has higher incidence of a stroke, about 3 to 4%, so a bit higher. So we do have some data. We found that in patients with TAVR using a self-expanding valve, the restriction time is associated with higher instance of capture or more debris in the cerebral protection device. More than 3 times is significant higher instance of larger debris caused by the cerebral protection. So even though the stroke might be silent, but we were worried about the long-term cognitive function decline or anything like that. So in younger patients, I agree with bicuspid. If you use a self-expanding valve, you should use cerebral protection. That's my opinion.
And I will say that this patient, you already start to pre-dilate, you're most likely going to have to post-dilate. So I think when there's multiple manipulation of the valve, especially highly calcified, you may have an argument. There's some sub-analysis that show that potentially prior stroke and also pre and post-dilation and self-expandable valve are associated with more the benefit of neuroprotection. So we may have a rationale to use neuroembolic protection in spite of all the negative data.
Any more comment?
I will say that we start to do leaflet splitting on the bicuspid type 0. So I don't know if the panel have experience with Basilica or Unicorn or Shortcut with bicuspid. I think this is a very hot topic right now. I think this is something that might be seen more often in the future to modify the bicuspid to make it more like circular and maybe also change the algorithm of sizing for TAVR.
Agree.
I have one question to all panels here. I see the location of calcification is one leaflet and the other leaflet has very little calcification. So is there any risk for migration because of calcium is so eccentric and anchor may be some resulting problem in this case. Any comment on that question?
Good comment. Actually, usually 66 we usually this kind of the bicuspid valve in the tower is actually not much experience because too early and the severity of calcium is not usual. Our bicuspid valve patient is a heavy calcium and the bicuspid valve and the elderly patient. Okay, I think your comment is good. Other comment from the panelists?
I think a smaller amount of calcium is good for the patient, good for the TAVR. I expect to end up with a very satisfactory circular deployment without much PV leak.
So if we go back to the case, Dr. Wang, Dr. Liu, you seem to deal with a very small hyperdynamic ventricle. What is your wire that you use? You're going to use a Safari, a Confida, or any other type? What LV wire are you using right now?
Thank you. So we will use the Lanoquist for this patient.
Is it routine for you, or is it just because it's a bicuspid? It's a very small hyperdynamic ventricle. We try to avoid Lundquist with those.
Yeah.
Yep.
Yeah, it's usually in my center. Mm-hmm. Yeah, it works quite well. Not only for the bicuspid and also for tricuspid.
Perfect. And you're going to use the pacemaker of the patient to rapid pace, or you're going to use the LV pacing?
So we will regularly, not the LV, the regular pacing, rapid pacing.
You mean the wire-based pacing in the LV?
No.
The pacemaker
No.
of the patient. Yeah.
Yes.
You mean the pacemaker induced? This is a permanent pacemaker, not the temporary one.
Still we use one. Yeah, from the jugular vein. You can see there from the X-ray.
Yeah.
Okay.
Yes.
So sometimes what we do, sometimes a lot of time we use the permanent pacemaker. We bring the controller and we use the permanent pacemaker. Or sometimes we have to be careful because sometimes those permanent pacemaker have threshold. Sometimes they cannot go above 160. Sometimes they have, here you have a double, make sure you don't pace with the atrium. You need to make sure you pace with the ventricle. So sometimes I just put a LV pacing. I pace on the LV to make sure we have a good drop of blood pressure and pace above 180. But that everything is possible. Yeah.
Understand. Keep going. Keep going to your procedure, Dr. Liu.
Okay, thank you. And then the gradient is about 70 mercury. And then we will do the BAV, tune observation.
So at first, what size
How do you select the valve sizing, Dr. Wang? Valve
we
sizing,
will use
valve
23.
sizing.
Yes, 23
23.
DMAT balloons. Because our annulus is 24. So we have to decide the valve size 26 or 29. So we use the 23 balloon.
Pre-valve.
And I don't see any TEE. Is it the patient conscious sedation with transthoracic and standby?
The patient, we use the intubation, the general anesthesiologist. Yeah, so we will not use TEE. We will TTE. Yeah, if we want to do that, then the echo guy will come here to help us.
So you're going to use a ZMAT balloon or another balloon?
ZMAT.
ZMAT.
Yes, ZMAT balloon.
So you always decide the size based on the annular average diameter, or you consider about the interconnection distance?
Yeah, we just combine the CT and the BAV. Yeah, so just based on the CT scan, so we will select the balloon. So just between the size 26 or 29, we will use 23 balloon. If the device the size 23 or 26, we will use 20. Yeah, so combine this.
So do you have any
And
preference?
classified in 4 groups. Group A, we will downsize.
So Shenbar, do you have any preference for the balloon type, a Z-Med or true balloon or much softer balloon?
Yes, I think both of them will works. Yeah, for the procedure. So, however, so we can just get the Z-band balloon in China. We cannot get a true balloon. 准备好了吗？
How many from the podium will do this case conscious sedation or with TEE, with TE guidance? I believe young patient with bicuspid, there's still a lot of uncertainty. This is potentially a case where we love to have TEE guidance to make sure that there's no catastrophe when we predilate, maybe help with the valve positioning, the leak assessment. Philippe, how you do those complex TAVR? I mean, obviously we know that most of the TAVR can be do conscious sedation, TT, but those complex young patients, how do you approach them in your practice?
Yes, I fully agree. We do more than 90% in conscious patients, of course. But in this specific case, patient is very young with BAV and risk of calcium migration. Sizing is not easy. And as you mentioned, I think balloon sizing is one of the good options. But if you have TE guidance in a sedated patient, that would be potentially an advantage to have to see the leaflet modification
那上已经准备好了啊。
and to follow the calcification and be sure that the procedure is safe.
What is the percentage, average percentage of the general anesthesia in your lab?
Oh, very, very few patients, only in these kind of patients.
差不多，这29。我们再回顾一下，放一下回放，好。So we can review the BAV.
So what is your assessment of this BAV? Or do you think you need another one, the balloon migrated, or you're satisfied with this?
It's not a perfect one.
When
Yeah,
doing
because it's migrated.
I think that the balloon and autovalvuloplasty, I think that the suboptimal result, the end autogram showed clearly should inform us sizing, about sizing, but this result suboptimal. So I recommend stable autovalvuloplasty during second attempt.
So we will not do the second one. So because
This is a
although
23 millimeter
balloon-
valve, right? Balloon.
Yeah.
Okay.
So you can see, although the balloon, the migrated. So however, you can see, just one by one. You can see the information right here. Yeah. So we opened the calcification, and there's no severe waste right here. So I think we will choose 29 for this patient.
So Evolut Pro 29, right?
Yes. You agree with that?
Yeah, it sounds very reasonable. I think that's a great choice. And where are you going to place the valve? What is your strategy in terms of the depth of the implant?
Yeah, so because of the Evolut Pro is soft compared with that of the Venus. So, and we also worry about the migration of the valve. Yeah, agree with that? So the depth, so we will try to the standard. So maybe 4 millimeter deeper.
when you do perform the predilation, is actually I see that there is no upward movement of the calcium region. There is no movement. What does it mean? Is predilation is really effective or not? I'm not sure. Please show the angiogram again during the predilation.
Okay.
Actually, at that time, the calcium maybe usually
Not
move
move.
to the
Not move. Yeah.
So no movement. What does it mean?
So I think that
So
the
you
valvular
wanna do it
expansion
again,
and
or-
improving risk is high if you do perform TAVR using self-expanding valve. As you can see, calcium fixed, non-move. So valve under expansion or improving risk is very high, I think. What do you think about that, Doctor?
Huh?
Hong.
I'm not sure.
Yeah, the
It's
calcium.
terrifying,
So
like
there's
that.
not a lot of movement of the calcium in the raphe. So I think if I had to choose a S323, for example, a sapien valve, I will use a 23 in this case, not the 26. Okay, it's 446, 450, because to your point, the calcium didn't move. It's 141 with a 23.
So I
For
think
the
that-
overload, I think
Yeah.
the 26 might have been okay as well, because you're right, the calcium didn't move at all.
If you do use a self-expanding valve, I think that the valve impulsing or under expansion is high. If you do use a balloon expander valve with a sapien, rupture risk high, I think.
Wei-Hsian, your comment?
I would choose 26.
26.
I think it is not open the valve, so if me, it's one more the balloon and the morphology the change, and then the sizing, the selection is more.
Yeah, in this situation, sizing is very, very important. Okay.
Yeah, excuse me. Can I have a question?
Yeah.
Yes.
Yeah, shall we do one more redilatation?
Okay.
If we can open the calcification?
Yeah, that's
So
great.
because we have different opinion about that.
Okay.
Okay.
Go ahead. You
That's like-
Yes.
and
it's
you have
like,
you have like 15
educational
minutes. So let's go.
purposes is a very good suggestion. Dr.
Okay.
Hayashida, any comment?
Yeah, I will also proceed to the second inflation because
Alright.
it's quite important to open up the calcification. To stabilize the balloons, so it's quite important to decrease the blood pressure. We also need to push the safari wire to the left ventricle. What is the most important to hold the entire system to push towards the left ventricle to avoid upward motion.
再下去一点。好，下去一点点。好，差不多，没事，我们等会那个看了再说。上一期等会我说打就打。好，起搏200。好，血压下来了 ，ESA， 看情况不要着急。好，打造影机。好，引起搏。
A little bit movement, but it still looks like a resistance. It means that we have to a lot the TAVI procedure. It means that the calcium is so strong, hard.
Could you show me the one more time, Octora?
So right now we can see the waist right here.
Right.
So I will change my mind to 26.
26.
26.
26.
Very interesting
Okay.
cases. Please go ahead. We
So
are
the
learning
high
your
quality
cases.
of the BAV is very important.
I think the calcium is stronger than I expect.
Very interesting
Oh,
cases.
I'm sorry, only 10 more minutes left.
Okay, go ahead.
And the Hangzhou team
feel-
nicely demonstrated the very good predilation, and the slow inflation was also key to stabilize the balloon in this case.
Okay, so we will introduce 26. 好，防移一下，往下移，不，上面公移存。
I think for bicuspid valve, the use a Lunderquist is a good idea to make sure that you stay very central and you can you don't have bias on the wire, you go on the greater curvature. So
Yes,放大一点。
I think that's a very, very good choice for this particular case.
来，到了右足，到了右足， 再放大。好 ，OK。好，差不多。
When you start the deployment, there is the alignment is not actually parallel. There is some
但是对
gap.
面是哪里？对面还是比较平的，那边平的。你这个座位是在底部了，差不多。OK，we will start the alignment。130准备啊，它比较平的，不能太高。
Is this Pro Plus?
Just have a Pro, not a Plus.
Pro. Okay, good.
Yes,
16 French. Yeah.
yes. A little bit deep. I think it's okay. We just adjust right here. 慢慢来，不着急。可以。So what do you think of the position? 130起搏准备。好，起搏130。有可能还略微再深一点点。这个你顶再顶一点点，不要顶太多。慢慢来，对。可以。好 ，OK。好，大家看怎么样？可以。这个略微深了一点点。没事，我们先放着看看。好，起搏，停下来。So I think a little bit deep.
Yeah, too deep.
Too deep.
Yes, too deep. Yes. 来，我们再重新回收一下。好，起搏130。那这个时候你拉的力量也不要太大。起搏了啊！不急，慢慢来。
I think to rapid pace around 120, it's a good idea. Also during the recapture to have maybe a partial recapture, push on the wire.
Yeah, partial. Yes.
Yeah,
I agree.
And push a little bit.
Push a little bit wire. Yes.
Exactly, and then continue.
好。
I think it's very good technique.
Yes. A little bit higher.
A little bit. I think looks okay.
Because
here.
it tends to dive into the
Yeah.
ventricles, so it'd be nice to start from much higher position, if we prefer.
好，起搏停，看看血压，再做照影，稍微好一点。来，我们达到 Copeland view。达到左头。
I think this is a case where you have to push both on the wire and the capsule and the system to try to go on the greater curvature.
Stacking.
I think this is where the
Stacking.
Lundequist will be useful. But I think you need to have a pressure, so just try to make the system more horizontal.
And that is quite important technique.
好，照影。
I would say that, to be quite honest, this depth is not that bad. The patient already has a
Yeah,
pacemaker.
right.
You may have to post-dilate. I mean, I would be
Right.
happy to live with this.
Practically, current position is the
A
acceptable.
little bit deep.
Right, but
It's a
the
little
Yeah.
deep.
However, I would not like to push it higher enough.
Yeah.
So because the patient already has the pacemaker, we don't need to worry about that. So and the no regurgitation, I think the result is acceptable. I will release it right here.
Fully agree. And the patient is young, maybe the coronary will be easier to access. Not that it's
Yes,
an issue.
yes.
So I
起搏
think
130。
You have a very high probability of needing post dilatation. So I
Right.
think this test is okay.
For the average pro, I will worry about the too high implantation. So because of the post dilatation, it will a little deeper higher than previous one. Okay, just a
I
minute.
think it seemed to be beautiful to me. I think the valve is great. I'm not so. It would be
Also
good
the-
to be maybe a little fluoro sweep to see different angle of the valve, but it looks great. The pressure answer well.
那我们先，so we have to decide whether we should post dilate or not. 来，先把作为把导管拿过来，我们先打一个那个，等会打一个。
Please show the extreme, the RAO angle. Actually, in this view is maybe, so we clearly discriminate the more and more extreme RAO.
等一下，稍微等一下。
More,
Yes.
almost be more than a.
Show us a short axis view.
And the
Clear short axis view. Extremely
Yes.
areocranial view show us short axis view. So valve
Yes.
eccentricity we
understand
can
that
inform
one.
of that from that view.
Yeah, this is the coplanar view. You can see right here the pre-compression right there. Yeah, we can see very clear waist in this projection. So I prefer to post-dilate.
And what size balloon you were going to use?
Yeah, 23. The
23.
previous one. Yeah, and then we will do the angiography, and we have time enough to finish the procedure. 来，23来，准备180起搏，200起搏。
I have
做完以后，我
I
们
have
这
to
个要
say,
他做
I
个
have to say so far it's a very good demonstration of the complexity of bicuspid sizing. You know, all
Well,
bicuspid, every bicuspid is different, and I think this is a good example.
那么开始慢慢做啊。
Anyone on the podium will have choose a balloon expendable in this case, or everybody? Raise your hands. Who will have choose a balloon expendable on the podium? You? 2, 3? Okay, don't be shy. That's good. Maybe. I will be, if I use a balloon expendable, I will use a TE.
好，再来下去，
And we'll follow carefully.
慢慢来，不要着急，慢慢来。好，再来顶一点。好 ，OK，good， 好，
This kind of
Ah.
the
准备
true by type 0 by
200起搏
cases,
往里面顶一点
the
点，
chance of
不要
the
起不要那个取消
post
联动
dilation is on the more
起
higher.
搏200，
So
顶牢一点，
especially in the young
把它
age,
顶牢一点。
too much high the post dilation is a population. So
好
Yeah.，
顶起搏。
Wow, that was a,
来，
that
我
was
们
a
换。
big expansion. Wow.
Yes, big expansion. Yes.
Okay.
来，再换座位来。Take a tail, please.
pre-shows the once again the post dilation is dramatically
Sure.
increased. It's the educationally for the audience pre-shows how much expand in the real time.
Expansion is high, but recollapse, some degree of recollapse.
So you can see
You
the
can see.
calcium. I don't know if you broke the raphe, but you can see the calcium just got pushed on the side. You can see if you play. So you see here is a vertical, and it just can completely vertical.
Dramatically increased, expanded the waist of the valve in the system is a very really dramatic. And at the time, the calcium was moved to the outside and more. It's a very dramatic image.
好，再楼。
I think some of
So
the
we will have the
connection
final
Kills-
angiography.
at the balloon inflation.
Before that, pre-show was the simultaneous pressure
OK，来，
between the LV and aorta.
先做造影，造了以后，我马上就做那个。A little bit deep.
This is a fantastic case, fantastic result, given the complexity of the case. I think even if a little deep, I don't think the depth of this valve will play any major role on the evolution, the clinical
Right.
evolution of the patient.
Actually, depth of the valve in this patient does not matter. It does not influence any clinical outcome. I like
And
it.
the gradient is about 4.
Excellent.
You can see 把流动力学放到大屏幕，
It's a great result. Yeah.
Could you
导播。
Is that very good?
Thank you. Thank you so much for your very good suggestion for the second valvuloplasty and select 26. Thank you so much.
We have a remaining time. We'd like discuss about the more in these cases. Okay. Correct.
Yeah. Well, I just want to thank you, the operators. It was a fantastic demonstration of a very complex case. So congratulations and thank you for showing us your skills. And we're going to move on. But thanks and congratulations again on a great case.
Congratulations.
Thank you so much.
Okay, so we're going to move on with the next speaker. It's my pleasure to introduce a spectacular speaker. Davide Capodanno is going to discuss a very interesting topic, the clinical syndrome of transcatheter heart valve thrombosis, diagnosis, and management.
The kind presentation, and I was asked to discuss an emerging entity, which is valve thrombosis. We normally talk about alt subclinical valve thrombosis. We say probably we do not have to worry too much, but this is something to worry about because we're talking of thrombosis that, of course, generate symptoms and also complications. This is my financial disclosure. And it's not trivial, it's not negligible, I would say, because this is the 5-year outcome from Partner 3, the balloon expandable valve, published in 2023. They applied the definition set by Philippe Genereux and colleagues by the Academic Research Consortium, so VARC3. And with this pretty sensitive but also specific definition, which of course require a thromboembolic event and a clinical manifestation of the thrombosis, the thrombosis rate with the balloon expandable valve is 2.5% at 5 years, as compared with 0.2% with surgery. So this is non-trivial, especially if you compare the two modalities. And what is also striking to me is that most of the thrombosis cases are what we would say in the PCI world very late. So after 1 year, 2.1% versus 0.2%. So this calls into question, in my mind, the antithrombotic therapy, because of course the technical factors should generate thrombosis earlier rather than later. So 2.1% between 1 and 5 years, remarkable. One of the reasons why the surgery and the transcatheter procedures have different rates of thrombosis may also stem from this model, which is interesting because it shows the fate of microparticles, particularly in large aorta, in the new sinus that is generated after the implant of the valve. So essentially, in this kind of new sinuses, there is tendency of these microparticles to stagnate, and the washout is less than, of course, in the surgical procedures. So this is one of the reasons why transcatheter procedures, particularly with the balloon expandable valves, may have more thrombus formation as compared with surgery. And maybe as compared also with the self-expanding valve, because we have seen recently the 5-year data, finally, for the Evolute low-risk trial that have been published a few weeks ago in JACC. And here the clinical valve thrombosis is 0.3% and surgery 0.2%. So for surgery is the same percentage. For TAVI, it's a different percentage, although I must say that here they use trial-defined criteria, not the VARC3 definition. So, of course, this may generate some difference, but it's an interesting observation that perhaps the valves may behave differently with respect to this outcome. Of course, we do not have, at the moment, long-term comparisons of the two types of valves, so we cannot really speculate more than that. But now the talk is on diagnosis and management of clinical valve thrombosis. For the diagnosis, I would say that this is not really too much controversial. Essentially, you would suspect a clinical valve thrombosis when you have a patient with a prosthetic valve and one of these following conditions. The first is recent dyspnea in a patient with a prior valve. Of course, this matters. Recent heart failure symptoms or hospitalization, an embolic event, and an unexpected increase in transvalvular gradient. So whenever you have one of these 4 conditions in a patient with a valve, of course, the first thought is about a clinical valve thrombosis. And in Europe, we do not have recommendations for imaging. In United States, ACC and AHA issued a class 2A, but level of evidence C, because there is no real evidence in this domain, for 3D TEE or 4D CT imaging, which can be useful in order to rule out leaflet thrombosis. So it's an exclusion diagnosis more than a rule-in, and this is for patients with suspected bioprosthetic valve thrombosis. This is how the pictures look like, and we are getting more and more familiar with this kind of TE and 4D CT analysis that show us the thickening suggestive of thrombus. For the thrombosis management, we have, of course, more information. And again, the evidence is not excellent. Here it's level of evidence B, and it's still a class 2A in the guidelines from America 2021. And essentially, when you suspect a clinical thrombosis, the initial treatment is with a VKA. It's deemed to be reasonable in patients with suspected or confirmed bioprosthetic valve thrombosis who are hemodynamically stable and have no contraindications to anticoagulation. So these two aspects are, of course, important to keep in mind. This is an extrapolation because these are not data generated in patients with clinical valve thrombosis, but this data apply to general patients undergoing TAVI. However, what is clear in this story, both in Galileo 4D using rivaroxaban plus aspirin, and in Atlantis 4D CT, which is a study of Atlantis using apixaban, is that the anticoagulant-based strategy is much better than the antiplatelet-only based strategy in taking care of thrombosis at the level of the valves. So if the question was whether we should use an anticoagulant targeting fibrin or an antiplatelet targeting platelets, the question is straightforward. We should use an anticoagulant because these trials gave results that were somehow consistent in some respect and not consistent in others. Particularly Galileo 4 was a trial negative for rivaroxaban plus aspirin, which means that this is not a strategy that we can routinely offer to patients. However, in the sub-study, there were less leaflets with reduced motion grade 3 or more, and in Atlantis, there were less obstructive valve thrombosis. So when we have a patient with clinical valve thrombosis routinely, we should use this strategy, and these are data with the NOACs, so of course it's an important piece of information as compared with the VKA. So this is a potential treatment algorithm for patients with a clinical valve thrombosis. It's a bit complex, but I think it's very meaningful and full of information. So essentially, you may have a patient who is not on any drug at the time, but this is very unlikely because, of course, these patients must be on a drug. And normally this drug is an antiplatelet or it's an anticoagulant, NOAC or VKA. So let's start with the antiplatelet. The patient has thrombosis despite the antiplatelet, so this was not the good idea. So there are two options to start the VKA, as we said. This is probably the most indicated and supported by data recommendation with a target INR between 2 and 3. Otherwise, an option is also to start a NOAC with the less data, as we said. Then, of course, this may resolve the thrombus or may not resolve the thrombus. If, of course, we try with the NOAC and the NOAC doesn't work, we will go to the VKA. If everything works, so we stop the oral anticoagulation, we repeat the imaging in order to check for the recurrences. So there will be a kind of follow-up series in these patients, of course. If all of these strategies do not work, then we have to continue or try other strategies. And particularly, if we still have thrombus in the setting of NOAC therapy or VKA therapy, the only thing we can do essentially is to increase the intensity of anticoagulation, so go from an INR of 2 to 3 to an INR of 2.5 to 3.5, and there are also considerations on the addition of antiplatelets in order to escalate in this patient and realize a dual pathway inhibition. But of course, we are really going into a data-free zone. Of course, these strategies may fail at one point in time, and then we are left only with thrombolysis or with reintervention. And of course, reintervention is not a piece of cake in these elderly frail patients who have been denied surgery at the time of the first valve. So obviously now it's a kind of bailout solution, and it can be even worse with high mortality rates. Although in expert hands, of course, there are also series that show that this is feasible, complex, but in some patients, this is simply what you can offer, so the explant of the TAVI. So I would like to conclude with some illustrations of these concepts from real patients. This is an 82-year-old male patient, for example, with a history of stroke and atrial fibrillation. So directly after TAVR, there was an increase in the transprostatic gradient, and the patient underwent serial follow-up. 1 month after TAVR, there was a presentation with progressive exertional dyspnea and NIA functional class 3. The patient had atrial fibrillation, so he was left on rivaroxaban only because, of course, in this patient you should go with only one antithrombotic agent, and that agent was rivaroxaban 10 milligram once daily. A kind of strange, of course, strategy like Galileo, but of course it's not the dose of rivaroxaban you would expect in atrial fibrillation. So that was the result with the diffuse hypodense thickening of the valve leaflets, highly suggestive for thrombosis because of the clinical presentation in a patient with a prior valve, as we said. And this is the gradient before and after a switch to acinocumarol with a target INR of 2 to 3. So before, you see in the upper part, the mean pressure gradient was 30 millimeter of mercury, the peak velocity was 3.5, and after a small reduction, but not normalization of gradients. So the mean pressure gradient was 22, the peak velocity was 3.2 after 3 months from a VKA initiation. So this is that situation where you have to decide whether you want to increase the intensity of the INR or add an antiplatelet or just continue the follow-up because the patient didn't worsen at least. Another case, quickly, 70-year-old male patient, and this is complex because this is a situation that we may see more and more in the future. This patient has 3 valves. So history of atrial fibrillation, CABG, a previous homograft AVR, and then TAVI in a surgery intervention with a Levolut R, and then a TAVI in TAVI with a Sapien 3 Ultra inside the Evolut, inside the homograft. So this is really, you may say, a nidus for thrombus, and the patient presents 19 months later than the latest TAVI with an acute heart failure and elevated cardiac enzymes. And the patient was on edoxaban 60 milligram once daily because, again, of the atrial fibrillation. So this was the imaging with alt of all the valve leaflets, a thickening of the left leaflets, a suspect for thrombosis in particular. And in this case, they opted for this protocol of ultra-slow alteplase infusion, which means 25 milligram for 25 hours that can be repeated without bolus. So essentially, this is meant to decrease the risk of bleeding complications, which remain very high in this elderly and frail population, of course. However, in this case, it worked because before the infusion, you had this 4 meters per second, and after the infusion, it normalized, or at least it was reduced to 2.4 meters per second with a gradient of 9, 6 days after the first alteplase infusion. So then the infusion was, of course, repeated. So I would conclude by saying that clinical valve thrombosis is a rare occurrence, often overlooked in early comparisons of TAVR and SAVR, so this outcome has to be scrutinized in next studies reporting long-term outcomes. There is need for more evidence regarding the long-term outcomes and the comparative safety of different types of valves, because now we are entering the era of TAVI comparisons more than indication trials. It may be suspected based on clinical presentation and elevated mean gradients, particularly in TAVI patients experiencing stroke, myocardial infarction, or heart failure, so thromboembolism, and can be confirmed via CT or TEE. The patients with the clinical valve thrombosis should initiate anticoagulation for at least 3 months. This is also an ex adjuvantibus criterion in order to detect whether this is really thrombosis or another reason for deterioration or dysfunction. And finally, if the symptoms do not improve or worsen during anticoagulation, thrombolysis or even aortic reintervention, unfortunately, should be considered. Thank you.
So Davide, as usual, fantastic talk and beautiful slide. We're running out of time, but I have one quick question for you. So sometime when we see those patients, elevated gradient, out or thrombose confirmed, we put on NOAC, 3 months later, they're still elevated. Sometime I use Lovenox, 6 weeks of subcutaneous Lovenox, and it did the trick a couple of times. What is your opinion on this before, putting more coumadin or putting other agents? So.
Yeah, I must say I do not trust really DOAC in this setting after Galileo, particularly. Probably the type of thrombus that is there is a contact pathway thrombus that is difficult to dissolve with NOACs. In Galileo didn't work, and with the mechanical valve do not work. So I think there are no real data for DOACs other than the extrapolation we have seen from Galileo, et cetera, but this is not a specific trial for that purpose, so I would go for VKA or, as you said, parenteral anticoagulation, which I think is something you can control and probably also creates less bleeding issues if well managed.
Okay, so we're running out of time, but I want to thank Davide for a fantastic talk. The center for the live case was fantastic, and the panel for a great discussion. So we're going to close the session. Thank you so much.